Dr. Kariann Abbate is a board-certified cardiologist specializing in heart failure at the Valley Hospital. With a holistic and patient-centered approach, she treats advanced heart failure, pulmonary hypertension, hypertrophic cardiomyopathy, and women's heart health issues. Dr. Abbate is part of Valley's outpatient transitional care team, helping patients transition safely from hospital to home and reduce admissions. She's been involved in multiple clinical trials, including the Paragon heart failure and CardioMEMS studies, and has contributed to heart failure research published in the Canadian Journal of Cardiology, a trusted provider within the Valley Medical Group. Dr. Abbate is currently accepting new patients in Paramus, New Jersey. Thank you so much, Dr. Abbate. You may start.
Thank you. Thank you, Kathy. And thank you all of you for joining us on this beautiful day. Happy Earth Day. We're so happy to have you. We're going to talk today about managing advanced heart failure. The reason this is important is heart failure is common. 1 in 5 of us will have heart failure at some point in our lives. And if we get hospitalized for heart failure, we consider that a sentinel event. That's a big deal. The reason for that is that if you get hospitalized for heart failure, about half of the people hospitalized will be, will pass away within the next 5 years. So whenever we have a patient who's hospitalized for heart failure, that's a red flag to us that says we really need to pay close attention to this patient, and we need to really be aggressive about managing the heart failure symptoms and trying to improve the patient's heart health so that we can improve longevity and decrease symptoms. So there's many ways to classify heart failure. There's a functional method that we use called the New York Heart Association method. And then there's a more structural method based on what the heart looks like and what kind of symptoms patients are having. So if you look over in the green, this is stage A, and this is a group of patients who don't yet have any symptoms of heart failure, and their heart actually structurally looks normal when we look at it on imaging studies, but they have risk factors. And we like to make sure that we're managing those risk factors as perfectly as possible so we can avoid progression into a different stage of heart failure. So someone who we're trying to be preventative and they have risk factors such as high blood pressure, diabetes, would fall into that category. The second stage is pre-heart failure. So this is, again, a group of patients who don't have any symptoms of heart failure, but now we're starting to see structural changes on their cardiac imaging that suggest that if we don't do something soon, they may begin to notice symptoms of heart failure. So for example, if someone has high blood pressure, we might start to see thickening of the walls of the heart on the echocardiogram, and that tells us that the heart's starting to change in a deleterious way because of their underlying conditions. So we really want to optimize those conditions to reverse these changes that we're seeing. When a patient gets to stage 3 heart failure, we not only see the structural changes of the heart that indicate there's some abnormalities, but now they're starting to notice symptoms of heart failure. So this is a hospitalization or a shortness of breath when we're walking or going upstairs, or when we're sleeping at night, we're feeling short of breath that we have to prop our head up. Those are all concerning symptoms, and that is an indication that we really need to start to be aggressive with medication management and perhaps other treatments that can help improve heart failure symptoms. And sometimes patients can fluctuate between stage C and stage D heart failure. You know, they could become very symptomatic with heart failure, and if we optimize them, they can move back into the stage C category. But the category where you would need advanced heart failure medications or treatments would be stage D. That's where you have symptoms even at rest or with very minimal activity. And that is a very dire situation where we really have to start to think about considering these advanced therapy options that I'm going to discuss later on. So coming down here to the black and white box, this is the functional classification of heart failure. And this is something that can fluctuate. So when patients are feeling good and they're not retaining any fluid and they're optimized on their medications, They may be in either class 1 or class 2, where they have no symptoms of heart failure, or when they exert themselves pretty aggressively, they note symptoms, but they could do most activities of daily living quite easily. When we get into the New York Heart Association functional classes 3 and 4, that's where we struggle to do our activities of daily living and might even notice symptoms at rest. And again, very concerning symptoms that warrant aggressive therapy. So I just want to show you why people feel short of breath when they have symptoms of heart failure. So this is a normal chest x-ray. And the things I want you to take note of are the heart, which is in the center here, this white structure. It's considered to be normal in size. You can see there's a lot of black, which is good because air is supposed to be black on a chest x-ray. So this is considered normal. Now, contrast to this study, which there's a lot more white, and we don't want to see white in the lungs on a chest x-ray because that indicates fluid. And the heart, which is the kind of more intense white structure here, is enlarged. So you can get an enlarged heart when you have heart failure, and you get a lot of fluid in the lungs, and that causes us to feel short of breath. So other symptoms that you may note with heart failure are you can see swelling in your legs or ankles. You may gain weight because we're retaining fluid. When you lay back at night to sleep, a lot of times you notice shortness of breath. And the reason for that is when we're sitting upright, gravity is going to pull the fluid kind of down into the lowest point. So that's when you'll see it in the legs and, you know, sometimes in the belly. But when we lay down at night, the fluid equilibrates and it could go into our lungs. And that's what triggers us to feel really short of breath when we lay back. And sometimes you hear people with heart failure having to sit in a chair to sleep, or they sleep in their lazy boys because they really can't lay back because of the fluid. Some people get cough when they sleep because there's fluid in the lungs. People are tired, and one of the reasons for that is if our heart pump is weakened to the point where we're not able to adequately perfuse our organs and our brain. Even if the brain and our other tissues in our body are not getting good oxygen, it's going to cause us to feel fatigued, and we're going to get short of breath and not be able to exercise as much as we want. So when we're trying to make the diagnosis of heart failure and keep track of people and track how they're doing, there's several tests that are often recommended. So the chest x-ray is one that I showed you before. We do routine blood work to check to the health of our other organs, because if the heart pump isn't pumping blood adequately, the other organs in our body can get irritated, and we can detect that by blood work. So we may see the kidneys getting irritated or the liver getting irritated. We also check this number called a BNP, that stands for B-type natriuretic peptide. And that's a marker of how much fluid's in our body and if we're retaining water. An echocardiogram is an ultrasound test where we use ultrasound to get pictures of the heart, and we can determine how strong the heart is, how our valves are working, if there's any wall motion abnormality of the heart muscle. So that gives us a lot of information that can help treat the condition. And then cardiac MRI is kind of an even more detailed imaging study than an echocardiogram that could tell us if there's any scar tissue in the heart, any inflammation. And a cardiac catheterization is a test where we can determine if there's any blockages in the coronary arteries that can be triggering the symptoms. We can also do what we call a right heart catheterization, where we measure the pressures in the heart and we can get an exact measurement of the cardiac output, or the amount of liters per minute that the blood is circulating. So there's many medications that we use to treat heart failure. We like to divide heart failure into two categories. So there's a category of heart failure where our heart muscle is weaker than it should be. And we measure the strength of the heart by a number called ejection fraction. So when we look at the echocardiogram, each time our heart squeezes or contracts, we should eject about 55% of the blood volume. If the heart strength is weaker than that or diminished, that is what we call systolic heart failure. And there's a lot of good therapies that we use to strengthen the heart, to get the heart muscle stronger. We use diuretics to manage symptoms of fluid overload. And then the next 4 drugs here on the list, they're considered the 4 pillars of heart strengthening therapy. We call that guideline directed medical therapy, or GDMT. So we use those 4 pillars to get the heart back to normal strength. In some patients, if they have a specific pattern on their EKG, sometimes special pacemakers can help strengthen the heart as well. So that might be something that's recommended. There's another kind of heart failure where the heart strength is normal, but the heart gets stiffer, either due to the aging process or some other sort of infiltrative process. So I equate the heart to a balloon, and a young, healthy heart is like those balloons where when we blow into it, we don't need to blow with very much force, and we get a nice big round balloon. That's because young, healthy hearts have good elasticity. As we age, or due to other infiltrative processes, our heart turns into those balloons where you have to blow more forcefully to get the air in, and you don't get quite such a big balloon. It's a smaller balloon because the heart is stiffer. And that's a situation where we can also retain fluid and notice a diminished exercise capacity. There's many comorbidities that can contribute to the stiffening of our heart, such as high blood pressure, atrial fibrillation, anemia, kidney disease, being obese or overweight. So when we see this stiffening of the heart, we try to optimize or make these risk factors as perfect as possible to minimize symptoms. So even despite our best medical therapies, different pacemakers, managing comorbidities, unfortunately, sometimes heart failure progresses, and it could get worse as we get older or over time. And we need to be able to know when the heart condition is getting to a point where we need to take more aggressive actions. And in the heart failure community, we use this acronym called I need help. That helps us know what to look out for, that tells us that the heart is getting worse and we need to be more aggressive. So the first is if patients need a medication called inotrope. So when people are hospitalized, sometimes we use this IV medication to help give the heart a little extra squeeze to help get better blood flow to the other organs of the body. So when patients need that type of medicine, that tells us that they're getting to a point where we need to be more aggressive. When they have New York Heart Association class 4 symptoms, so that means shortness of breath at rest, when they're so short of breath, they can't even do their activities of daily living, such as getting dressed, walking from the bedroom to the bathroom or the bedroom to the kitchen, preparing a light meal. Those are signs that the condition is deteriorating. If we start to see the end organs becoming irritated, we start to see the kidney numbers or the liver numbers getting worse, that's a bad sign. If the ejection fraction or the strength of the heart falls below 20%, that's a sign that things are worsening. And people who have ICDs or defibrillators, if they're starting to get shocked because the heart is going into bad rhythms, that's a sign that things could be getting worse. If people are in and out of the hospital constantly because of heart failure, again, a bad sign. It tells us that they're starting to decline. We need to be more aggressive. If we're giving them lots of water pills, lots of diuretics, but they're still feeling short of breath and they're still retaining water, that's a clue that we need to be more aggressive. If people's blood pressure goes down and we have to start backing off their guideline-directed medical therapy because of low blood pressure, that's a bad sign too. It tells us that the heart pump is so weak, we can't even generate a normal blood pressure anymore. So that means we need to look into alternative therapies. And the reason that we need to pay close attention to these signs of I need help is because when we get to this stage, we have this golden window of opportunity where you will benefit from these advanced therapies, but it's not too late. If we wait, if we don't identify these signs and symptoms at the appropriate time, and we start to get organ failure and the liver and the kidneys have irreversible damage, or people become so malnourished and so weak that they can't handle the procedures and the surgeries that are necessary to treat the condition, then we may have missed our window. So when you start to notice those signs, the I need help signs, that's a clue that you need to be in close contact with your cardiologist so that we can make decisions in a timely fashion. So what are advanced cardiac therapies? So we touched on the first group of advanced therapies. So these are the medications called inotropes, and they're intravenous medicines. Unfortunately, we don't have them in pill form yet. So if people are needing them and they find them helpful and they're feeling better when we start them in the hospital, many times we send people home with an IV medication. So we'll put in a sturdy intravenous line called a PICC line, and the patients go home with a special pump with a continuous infusion of medication, kind of similar to people with diabetes who need an insulin pump. It's a similar mechanism. So these are helpful to keep people functional, to help them feel better so that they could do their activities of daily living. But these medications are usually considered a short-term option as a bridge to something else, because unfortunately, these medicines have side effects. They can cause rhythm disturbances. We've done a lot of research with these medicines, and they actually don't help people to live longer. They may help people to feel better, but they're not something that's going to improve our longevity. So we usually use them as a bridge to a more definitive therapy when we need them. Sometimes we do use them as a kind of a definitive therapy in people who are older or who maybe don't qualify for other advanced therapies. But we always want to make sure that we're evaluating the patients to see if they're candidates for the next steps. So heart transplantation is considered advanced cardiac therapy, and it's a really good therapy, and it helps people to restore their normal functional capacity and to get back to doing the things they want to do. But there's a few drawbacks to cardiac transplantation. So one is we don't have enough hearts. So, thankfully, over the years, there has been an increase in the number of heart transplants that have been performed in the United States. And in 2023, there was 4,545 heart transplants. So that's great. But unfortunately, globally, we need 50,000 hearts to adequately serve the people that need them. So there's a very big discrepancy there. So this is not a viable option for everybody. And then there's some contraindications or some risks that make doing a heart transplant too risky for a lot of folks. So it's not a viable treatment for everybody. So that's where the LVAD comes in. So LVAD, it stands for a left ventricular assist device. And this is an implanted cardiac pump that helps the heart and it restores the normal cardiac output so that people can go back to leading a normal life and doing the things that they want to do without feeling shortness of breath. So there's many components to this system. So the pump is this small kind of metal structure that is surgically implanted to the apex of the heart. And then there is, this is kind of just a closer up picture. There's an outflow cannula that goes up into the ascending aorta. And this pump kind of acts like a vacuum cleaner. So it will suck the blood out of the left ventricle and it delivers it to the aorta and it pumps the blood to the rest of the body. The device is not completely internalized yet, unfortunately. So there's a drive line that becomes, that gets tunneled down and it exits the body in the abdomen. And then this drive line is outside the body and it attaches to this controller, which is a computer. It's like the brains of the system. When you're out and about walking around, the controller is attached to batteries and the batteries last like 10 to 12 hours. And when you're home, if you're watching television or you're sleeping, you can plug the pump into a wall. You don't need to wear the batteries when you're sleeping. So I just wanted to show a video. Actually, let me escape here and see if I can find my video. Are you guys seeing the video?
Yes, Dr. Abbott.
Okay, thank you. And can you hear?
I can probably put the volume up a little bit more on your side. Mhm.
After that, I had many of them smells like that. 30 feet, sometimes without grabbing onto something because I was getting so bad.
We kept going to the emergency room quite frequently.
It got to the point where we didn't even call 911 anymore for the ambulance. We just drove ourselves. I couldn't sleep. It's not sleeping pills. I was very depressed. Very weak, very slim. That wasn't me.
We couldn't do anything, you know, and he normally want to go and see his grandkids then, and he just want anybody around, really. We had another follow-up appointment to see where we were with the medication, and things just weren't progressing the way we wanted them to. And he just kept getting worse and worse.
My cardiologist decided I qualified for the Abbate 3 and said, can we put it in this afternoon? So ever since I've had my Abbate 3, every day has been just amazing. I have not been in the hospital for my congestive heart failure at all. It just makes such a difference because you get the flow of blood. Started biking at 10 weeks. At 21 weeks, I started golfing again. And at 10 months, I was skiing. Since then, it's been a whole spiral.
Yep, we do pretty much everything we want. We're able to go to the grandkids now, and he's able to enjoy them. You know, that was one really big thing that he didn't want to miss out on is the grandkids.
I take them fishing. Now they're starting to play lacrosse. One's got a girlfriend, so I got to help educate them on that. They're amazing. And absolutely. I give them a second chance.
Give it a second chance in life, you're going to take it.
We're due.
So that was just a video of a patient who ended up getting this heart pump, and it really helped restore his cardiac output to the point where he could go back to exercising, golfing, doing the things he wants to do. So again, this is a heart pump that it's not for everybody. There are some patients who, again, it could be too risky, but it's definitely a good therapy. And for the right patient, it really makes a huge difference. And the reason why this therapy is considered when, you know, as a more permanent therapy, when people are on those medications called inotropes, is because there is a longevity improvement. So people will live longer when they get this pump compared to those people who are in the same category of heart failure who don't get the pump. So if you look at this graph here, the black line on the top is people who get heart transplants. And this is looking at people 24 months after surgery. So heart transplantation is still the gold standard. And after 2 years, people who've had heart transplants, 82% are still alive. Now we have to consider that people who get heart transplants, they're usually on the healthier end of the spectrum, and they're usually on the younger end of the spectrum. Usually by age 72, most transplant centers kind of cut people off and say, you know, not a candidate anymore due to age. So people in the heart transplant category are going to be younger. They're going to be people who don't have any histories of any recent cancers, that type of thing. So 82% survival at 2 years with transplant. But the HeartMate 3, that video I just showed you, the heart pump, 79% of people are still alive at 2 years, which is a pretty good number considering that the people who get HeartMate 3s are usually older and maybe have other comorbidities that make them not as healthy as the people who would have gotten a heart transplant. So that's pretty good. This is, we would call this equipoise, where the survival curve is pretty much the same for HeartMate 3 and heart transplant. And I just like to give you a little perspective and direct your attention to this bottom yellow line here, this 8% number. So OMM is optimal medical management. So people who we just treat with medications or treat with those IV inotrope medicines, only 8% of those folks are alive at 2 years. So once you need the inotrope medication, if we don't go on to a more advanced therapy such as a transplant or an LVAD, then the mortality rate is quite high. So it's really, not a great survival curve here. Now, a lot of people look at the heart pump. Let me just pull it back up and say, wow, that's a lot. It's not something I would want. No, I don't want to have a drive line coming out of my abdomen. I don't want to have to walk around with a computer and batteries attached to me. And it's true, it would be better if everything was internalized, and it's not ideal. I don't think any of us would choose that if we could avoid it. The problem is once you get to that point where you require that type of therapy, without it, there's a high mortality rate. And we kind of equate it to having advanced cancer. If you get to that point where you're being considered for an LVAD, it would be the same as needing chemotherapy. And even though none of us would choose that, if we could avoid it, that is something that sometimes is necessary to treat the condition we have. So we have to kind of do the best with what we have. When people need these advanced therapies, you're not alone. It's not a journey that you will be undertaking by yourself. You will have a whole team of people surrounding you to help you succeed with this therapy. So you will have a heart failure specialist, such as myself. There'll be a cardiac surgeon. We have an excellent surgeon here at Valley, Dr. Paul Burns, who's implanted hundreds of these devices and is an expert. You'll have a lot of family support, and we train the families and friends to help people manage their devices. And then we have all these other specialists who are in the periphery who help with medications. We have nurse practitioners. We have an LVAD coordinator who becomes, her name is Nancy, and she says she bubble wraps her patients. She makes sure that they're insulated and that they have all the support that they need. And this whole other group of people, and even more people than are on this list, are helping you manage the LVAD and to succeed with this therapy. So I often say this, anybody who has heart failure, it takes a village, because it's not an easy condition to manage, but it's definitely manageable. It's definitely treatable, and you can live a long, productive, healthy life, even with the diagnosis of heart failure. So with that, I'm going to end, and we're going to stop for questions.
Can you see the questions, Dr. Abbate?
I think I have to stop sharing.
Okay.
Oh, stop share. Here we go. Okay, there we go. Okay. So we do have a question. Oh boy. So someone asked a question about having symptoms of heart failure and having a lot of symptoms, especially in the hospital, and feeling like they didn't get the cardiac support that they needed. So I'm sorry to hear that. So, if you ever feel like you may be a candidate for these therapies or more advanced therapies, certainly reach out to me or the people on my team, and we're happy to, give you our thoughts and a second opinion and assist your cardiologist if needed. So another question came in, how long can you be on an LVAD? That's a great question. So there's really no limit. I've been working at Valley for 10 years. I have some patients who have had an LVAD for as long as I've been working here, so about 10 years. So the pumps now are very durable. In the beginning, when we had the kind of first and second generation pumps, they could wear out over time, or they could develop complications. So sometimes we'd have to change them out and replace them. But the newer pumps, they last, 10, 15 years, maybe even more. A lot of the times, people who get these pumps, they start to get other problems that cause them trouble, and that the LVAD, keeps the heart going quite well, but they develop other issues, as we age, as all of us do. So a lot of times it kind of takes the heart out of the equation, so to speak. Oh, any age cutoff for LVAD? That's a great question. So there are no age cutoff for LVAD. People can get them even into their 80s. Once people reach the age of 80, we're pretty careful in terms of selection, because we find that the surgery to get it implanted, it's a big surgery, and we want to make sure that the people are healthy enough to handle it. So sometimes frailty becomes a factor in deciding if someone's a candidate or not. But if you're in your 80s and you're robust and otherwise, pretty healthy, there's really, that shouldn't be a deterrent, the age. We go on a case-by-case basis. What role does lifestyle management, such as diet, exercise, stress management, play in managing advanced heart failure? So that's an excellent question too. It's never wrong to lead a healthy lifestyle, and certainly it is going to help you succeed if you get that diagnosis of heart failure. There's research that shows cardiac rehab helps people to do better when they have heart failure. So exercise definitely helps. We recommend, when you have heart failure, to eat a low sodium diet, because where the salt goes, the water goes. So if you eat processed foods or foods with a lot of added sodium, you're going to do worse. So you really want to eat a clean diet, lots of fresh things, fruits, veggies, whole grains, lean meats, and stay away from processed foods, stay away from the salt shaker, and that will help you to feel better. And then, of course, stress management helps, because a lot of the medicines we use to manage heart failure help to modulate our neurohormones in our sympathetic nervous system. So if you're anxious and we're stressed out, we're going to rev up those deleterious hormones like adrenaline, and that can make our condition worse. So we really want to try to manage stress so that we can keep our hormones in balance. The next question is, the surgery for LVAD, is it kind of a less invasive surgery than heart transplantation? I would say yes, it is. It's going to be an easier surgery for the surgeon. From the surgeon perspective, it's a more straightforward surgery. It's still both surgeries are an open heart surgery most of the time. So the recovery from LVAD surgery is usually you're in the hospital for 1 to 2 weeks. But yeah, it would be a less intricate surgery than heart transplantation. I think that's all the questions so far, Kathy. Anybody else with questions?
Okay, that looks great. Thank you so much, Dr. Abbate, for your informative presentation this afternoon.